Support for the Journal of Clinical Oncology podcast is provided in part by AstraZeneca, dedicated to advancing options and providing hope for people living with cancer. More information at AstraZeneca-US.com.
Hello and welcome to the Journal of Clinical Oncology Article Insights. I'm your host, Joseph Mathew, and today we will be discussing the article Long-Term Survival in Resected Pancreatic Ductal Adenocarcinoma with adjuvant gemcitabine plus capecitabine compared to modified FOLFIRINOX from the ESPAC4 and the PRODIGE-24 trials by Dr. Palmer et al. To summarize the relevant evidence, the ESPAC4 was a European Phase III multicentric randomized clinical trial published in 2017 comparing adjuvant gemcitabine and capecitabine or GemCap with gemcitabine monotherapy following macroscopic margin-negative resections for operable pancreatic ductal adenocarcinoma. The trial had included non-metastatic patients aged 18 years or older, World Health Organization performance scores of 2 or less, creatinine clearance of at least 50 ml per minute, and a life expectancy of over 3 months, who had not received any prior anticancer treatment. Patients who had undergone R2 resections were selectively excluded. Eligible participants were randomized 1:1 within 12 weeks of pancreatectomy to one of the two treatment arms, with chemotherapy initiated within 2 weeks from the date of randomization. The regimens involved 6 cycles, each lasting 4 weeks for an overall duration of 24 weeks. In the monotherapy arm, gemcitabine dose at 1 gram per meter square was given as an intravenous infusion once a week for 3 weeks, followed by 1 week off, and in the GemCap arm, capecitabine dosed at 1,660 milligrams per meter square was added to gemcitabine given daily for 3 weeks, followed by 1 week off. Patients were followed up every 3 months, with the primary endpoint being overall survival. The study showed that at a median follow-up of 43.2 months, GemCap was associated with a significantly longer overall survival than gemcitabine alone. Subsequently, in 2018, the Phase III randomized PRODIGE-24 trial was conducted in centers across France and Canada, comparing adjuvant modified FOLFIRINOX with gemcitabine in a similar subset of patients with resected pancreatic ductal adenocarcinoma, and reported longer overall survival with modified FOLFIRINOX regimen. This study, however, had a more restrictive eligibility criteria when compared to the ESPAC4, including patients aged under 80 years, WHO performance status of 0 or 1, with no significant cardiovascular disease, and a postoperative serum CA 19.9 of less than 180 units per ml. There was hence a subset of ESPAC4 patients who did not meet the eligibility criteria for modified FOLFIRINOX as set by the PRODIGE-24. The present study was conducted to estimate the overall 5-year survival rates for patients of the ESPAC4 receiving GemCap and gemcitabine, further stratifying survival in either arm according to the status of the surgical margins and the resected nodes, and also to investigate whether GemCap retained a survival benefit over gemcitabine in PRODIGE-24 in eligible patients. A total of 732 patients, evenly distributed between both arms, were followed up for a median period of 104 months. Adjuvant GemCap was found to retain its survival advantage over gemcitabine with a significantly longer median overall survival of 31.6 months when compared to 28.4 months with gemcitabine alone. Further subgroup analysis was performed with reference to the resection margins and the nodal status. As a reminder, in the ESPAC4 trial, 60% of patients were found to have microscopically positive margins or an R1 resection, and 80% were node positive. The difference in survival was greater in patients undergoing microscopic margin-negative resections, who experienced a median overall survival of 49.9 months with GemCap when compared to 32.2 months with gemcitabine. Node-negative patients also had a significantly greater 5-year overall survival rate with GemCap of 59% versus 53% with gemcitabine monotherapy. However, it is important to note that no significant difference in survival outcomes was observed in margin-positive or node-positive patients in the two arms. The investigators also evaluated GemCap in the subgroup of 193 patients comprising 26.4% of the ESPAC4 cohort who were not considered to have met the eligibility criteria for PRODIGE-24. The survival benefit of combination therapy was retained in this group, with patients receiving GemCap experiencing a median survival of 25.9 months compared to 20.7 months with adjuvant gemcitabine. Although cross-trial comparisons have limited validity, good agreement was noted in adverse grade 3 or greater toxicity associated with the control gemcitabine arms of ESPAC4 and PRODIGE-24. serving as the basis for a qualitative comparison of toxicities between modified FOLFIRINOX and GemCap. Neutropenia was more prevalent in the GemCap arm, affecting 40.8% of patients compared to 28.4% with modified FOLFIRINOX. However, granulocyte colony-stimulating factor was administered to 62.2% of patients in PRODIGE 24. Palmoplantar erythrodysesthesia was also more prevalent with GemCap. Patients on modified FOLFIRINOX were more likely to observe grade 3 or greater fatigue, diarrhea, nausea and vomiting, sensory peripheral neuropathy, and paresthesias. The investigators concluded that GemCap was the standard adjuvant treatment for patients with pancreatic ductal adenocarcinoma undergoing an upfront resection, who are not feasible for modified FOLFIRINOX, with further exploratory analysis revealing that patients under the age of 70 who had undergone a microscopic margin-negative resection for node-negative pancreatic ductal adenocarcinoma were likely to derive an overall survival benefit from the addition of capecitabine to gemcitabine in the adjuvant setting, whereas modified FOLFIRINOX would be more effective than gemcitabine in patients with positive margins or involved nodes as per the PRODIGE 24 trial. Thank you for listening to JCO Article Insights. Please come back for more interviews and article summaries, and be sure to leave us a rating and review so others can find our show. For more podcasts and episodes from ASCO, please visit asco.org/podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.